Welcome to the Reapparition Journal podcast, where we explore the intersections of storytelling, humanity, and health. I'm your host, Taruni, and I'm the founder and editor-in-chief of Reapparition Journal. I'm thrilled to have you join us for this very special inaugural episode. Reapparition Journal is a platform dedicated to exploring the intersections of health, humanities, and storytelling. We publish thought-provoking works that examine the human condition, often highlighting voices and perspectives that challenge conventional narratives. Through fiction, essays, poetry, and more, we aim to foster deeper understanding and empathy across diverse experiences. Today, we're diving into the powerful and deeply reflective world of Mercury Descending, a short story written by our guest, Dr. Gary Moak, for Reapparition Journal's Issue 8. Dr. Gary S. Moak, MD, is a geriatric psychiatrist with many years of experience working with older adults and their families. He is Associate Professor of Psychiatry at the Geisel Medical School at Dartmouth and Director of the Geriatric Psychiatry Fellowship Program at Dartmouth-Hitchcock Medical Center. Dr. Moak is a past president of the American Association for Geriatric Psychiatry. He is author of the book Beat Depression to Stay Healthier and Live Longer, a guide for older adults and their families, published by Roman and Littlefield. Through his writing, he brings to life the challenges and triumphs of aging with remarkable empathy and insight. Mercury Descending tells the story of a 91-year-old Korean War veteran as he navigates the loss of independence and the complex emotions that come with aging. It's a poignant exploration of identity, autonomy, and how society treats its elderly members. But our conversation today isn't just about this beautiful story. It's also about the broader questions it raises. How do we define ourselves when the markers of independence begin to fade? What responsibilities do we, as a society, have to the aging population? And how can storytelling help bridge generational divides and foster greater understanding? Dr. Moak has also contributed to the Reapparition Journal blog with a thought-provoking piece on older drivers and the delicate balance between safety and independence. We'll discuss that too, and so much more. So whether you're a longtime reader of the journal or just discovering us today, I invite you to settle in as we explore these essential questions with Dr. Gary Moak. For your convenience, we have linked all of the pieces of writing we reference in this podcast in the description below so that you can follow along with ease. Dr. Moak, welcome to the podcast. It's such an honor to have you here.
Thank you. The honor is mine. I appreciate being able to join you today, especially for your inaugural podcast for this series.
Yeah, absolutely. Thank you. So to start off, your short story, Mercury Descending, is a deeply moving narrative that captures the challenges of aging through the lens of a Korean War veteran. For those who might not be familiar with the piece, could you please share a brief summary of the story?
Sure. So Mercury Descending is a story about three main characters who deal with aging coming from different perspectives. Um, the main character, or one of the main characters whose story it's really about, Colonel Kilroy, is a 91-year-old, highly decorated Korean War combat veteran who's struggling with deteriorating health, both physical and mental, in advanced age. And he's recently lost his driver's license because of that and is struggling with tremendous anger, resentment over that. The story is told from the perspective of two neighbors who live down the street, a younger couple who encounter him by chance coincidence and in their experience of him have reactions to this aging neighbor in ways that are hard to anticipate. In one case, the reaction is quite transformative. In the other case, not so much so. Prior to these encounters, he was really an invisible non-person to them. He's just the old guy that lives up the street, and both of them harbor ageist attitudes about him and older people in general of greater or lesser severity. The story is told through, it's actually a story within a story within a story because it tells Colonel Kilroy's story, but it's told, the narrator of the story is the husband who has no name in the story for reasons that I can go into later. And his wife, Carrie, her encounter with Colonel Kilroy, she tells his story. And the narrator, in listening to Carrie tell the Colonel's story, is also appreciating her story as well as she's transformed by her encounter with him. And we see his reactions to all this going on and compare them with her reactions. and in hopefully a way that most readers will identify with and feel somewhat compelling.
Right. Yeah. Thank you for that excellent summary. Yeah, and I really enjoyed reading the story. That was great. So I wanted to start off our discussion by talking about the title itself, Mercury Descending. At a literal level, I understood it as a reference to Kilroy's car, a weathered 1963 Mercury Monterey Breezeway, as it's described, and the decline of the car itself and potentially Kilroy's driving ability. But I also thought there was a double meaning to the title, potentially alluding to the Roman god of traveling, messengers, and speed, Mercury. Could you elaborate on this and talk a little bit about, first of all, like why you decided to name the story what you did, and the parallel between the description of the car and Kilroy's journey?
Sure, and there, is that sort of oblique reference to the Roman god Mercury. Mercury descending is also an astrological term, um, but mainly the two words are important. Mercury refers to the car, which in some way two vehicles, Sherman tanks and the Mercury, two vehicles in the story, are inanimate characters, but characters nonetheless, each symbolically representing an important theme in the story. And the descent or descending of Mercury in this case refers to the gradual deterioration of the automobile in parallel or concomitantly with Colonel Kilroy's own deterioration. And it's really a story about a major theme about how older adults come to terms with the ravages of aging and find ways to overcome that, maintaining their dignity, well-being, sense of purpose in life, or not.
Thank you. Yeah. Yeah, I definitely felt that while reading the story. So I mean, one section, like when speaking about the car, one section in particular that really stood out to me was the moment when Kilroy describes his dated car as being in mint condition, which contrasts sharply with, the younger man's internal monologue regarding the car. He says, mint condition, hardly. The bronze paint had lost its luster. The body was dented and dinged and showed signs of rot, and the chrome bumpers were pitted. This juxtaposition struck me as more than just a commentary on the car. It felt like a reflection of how they perceive Kilroy himself. Could you talk about the significance of these contrasting perspectives and how they parallel the broader themes of identity, aging, and the societal perceptions in the story?
Younger people tend to have a much different view of older adults than older adults have of themselves. In some cases, older adults become negative, depressed, and pessimistic about what's occurring in old age. But assuming they've maintained reasonably good health, physical and mental, and more mental than physical, actually, it turns out older adults have a higher level of well-being and happiness and life satisfaction than any other younger age group in our culture. They're actually doing better than most of us who are younger than they are. But we don't tend to see it that way. We tend to look at old age as something filled with despair, gloom and doom, misery, and the like, something to be dreaded. And but in this case, dealing with themes of driving, one of the problems, and in my years of practice, among the thorny problems and compelling, difficult, challenging problems I work with, are impaired older drivers who don't recognize their impairment and refuse to surrender their keys. And this is a huge problem for people. It's angst-ridden, it's anxiety-provoking, it triggers tremendous conflicts in families. And so in this case, the colonel neither sees his car, which in some ways is a reflection, an inanimate mirror image of himself, um, or himself as quite impaired uh, as he actually is. Doesn't recognize that he's an impaired driver, that he can't drive anymore. He's in complete denial of that. And he doesn't see the car in the kind of aged weather condition it is, which is his younger neighbor, being more objective, sees it for what it is and looks at it basically as an old beat up jalopy. That's a bit of an eyesore in their neighborhood.
Yeah, and I thought that was really interesting, especially in context with like how you also described the homes in the neighborhood in the story. I know that Carrie describes Kilroy's home as a teardown, and I don't think Kilroy would agree with that characterization. So I thought like even that world building and the building of the setting was really excellent in that regard. So yeah. I next wanted to move on a little bit to your inspiration regarding the themes of Mercury descending. So I mean, you kind of already touched upon this a little bit in your prior answer, but the themes in Mercury descending feel incredibly personal and nuanced, almost as if you're channeling real experiences into fiction. So what inspired you to write this story, and how does it reflect your work as a geriatric psychiatrist?
Yeah, I've been working with older adults for almost 40 years. A few more years, it'll be 40. And they're a really interesting, rewarding group to work with. They're very appreciative as a group. They're grateful for attentive medical care. And they're quite interesting. And I got into this field because of an interest in a specialty that it really appeared to sort of ride at the confluence of medicine, neurology, and modern psychiatry. But as I started to work with more and more older adults over the years, I really found many of their stories of trying to cope with aging and the changes that it brought and the losses they were facing and the ways they were successful or not so successful in rising above it, really moving and compelling, but a story that few people are aware of. Most people who have experience with an older adult, older adults themselves, or their children or other family members or caregivers, all have seen this, but it's rarely expressed in a way that people can relate to in a general sense. There really are a few stories um, in media. There are a few stories. There are a few, very few novels, other short stories, motion pictures dealing with these themes. And so I got interested in writing about it. And when I decided that I'd rather it'd be more compelling to write fictional accounts of things, novels and short stories, than try to write more nonfiction books. Um, this was, I thought, a good way to really reflect my experience and tell the story of the patients I've worked with over the years.
Thank you. Yeah, so this is a great bridge into what I wanted to talk about next, which is the character development of some of the key characters in this story. So, first, to talk about Kilroy, the protagonist, a 91-year-old war veteran, he's portrayed with such depth and vulnerability. His experiences, particularly around driving, resonate with universal fears about aging and autonomy. So how did you develop this character, and what aspects of his journey do you find most compelling?
It's interesting. So I had very mixed feelings about writing a story about where the main character was a combat veteran. Um, just because so many people have so many mixed feelings about that topic, and it can trigger a lot of memories for readers who may be old enough to have gone through those epics in history. But I ultimately decided to choose a combat veteran because I saw that as kind of the male image epitomizing the sense of kind of machismo and powerful competence of a generation of men who grew up in the middle of the 20th century. And the parallel there is the 1963 Mercury Monterey Breezeway that was really the heyday of the American automobile industry in the United States in terms of big, powerful um, uh, cars with cutting edge technology and design, really reflecting again a sense of prowess. It was really what I wanted to convey because in his case, he's struggling angrily so with age-related loss of his sense of ability and prowess. He's become weak and feeble, and this is not who he's ever seen himself as being. He's always seen himself as being a capable, powerful, able person, and it maddens him that he no longer is. So that was my what went into my thinking about choosing a war hero and using a Sherman tank as a symbolic reflection of him. Um, I initially wrote the story from his point of view in the close third person. And ultimately changed the focus to bring in these two additional characters. I thought it would be much more powerful to tell the story from the point of view of outside objective narrators who come at it from an originally ageist perspective, or at least a neutral position where they basically see him as kind of an invisible non-person, and then are transformed differentially during the story. And I hope that ended up being more compelling and more convincing to people.
Great, thank you. So on that same train of thought, I also wanted to talk about the young couple in the story a little more in depth. So they're pretty relatable characters, I think, for many people. And I think the moment we acknowledge that relatability, we're also able to acknowledge something within ourselves that may potentially have the same biases as these characters. So I was wondering if you could talk a little bit about your characterization of the young couple and specifically Carrie. I was very interested in her, shift after Kilroy's whole episode on the road. So yeah, I was very curious about that.
So she's an author. She writes novels, popular fiction novels, and she spends her time inventing fictional characters. She in her personal life she's intense, driven. She's maybe a little bit difficult at times, a little impatient with her husband, but she is a fierce, loyal, protective mother, and puts her family first, at least on par with her writing. So she writes, and she has really no sympathy for Colonel Kilroy. He lives in this house that you already mentioned. She sees as it's a very upscale, professional neighborhood with colonials and modern houses and split entry houses and the like. Um, and he lives in an old World War II vintage Cape Cod that years ago the others like similar on the block were raised in favor of these newer McMansions, but he's still there for various reasons that have to do with his attachment to his deceased wife. But she sees it as she has no patience for this. She sees it as a tear down. She doesn't understand what old guy is living in this neighborhood with younger up and coming couples and young children, and she's got no patience for this guy and wishes that he would just be gone. The husband who encounters him and her she encounters him maybe at his worst. The husband not so much so, but the husband encounters him when he's at his worst, when he's having his own moment, and he's a little less unsympathetic toward Colonel Kilroy, but not all that much. And ultimately, he's the one who's not really transformed. Carrie is transformed because of the circumstances under which she encounters him. She's sort of forced to end up hearing his history, his life history,
Right.
why he's in this home, what he's doing there, his attachment to the car. Um, and she hears an account of a chivalrous, heroic character who fell deeply in love with his wife during the war, had a world-class love affair with her then she died at an early age of cancer, and he's never gotten over that loss, and still is deeply in love with her. And this sort of moves Carrie in a way that doesn't really move her husband as much. He's very unimpressed by this, but Carrie is moved at a personal level. This is the kind of character she would love to write about, or would
Right.
love to have thought up herself. Um, and she's moved in a way, and finds him, wonders whether her own husband would feel the depth of love over 70 years of a period of grieving for her that Kilroy feels for his deceased wife. And it's this experience of being moved in this way that really discovers that he's a person. He's a person with a history. He's a person who's been through some pretty horrible circumstances in life and came through okay and rose above it. He married, he had children, he raised a family, and found a way, even despite the loss of his beloved wife early on, to live the rest of his life and make it to age 91.
Right. Yeah. And I also did find that contrast between Carrie and her husband very compelling. And I also thought it was interesting how the first time her husband even meets Kilroy, he basically meets him because he fell down because of a knee injury, like an old sports injury, is what it said, I think. And in a way that was very interesting to me because in a way that like I think it also mentioned in the story that when you're a kid and you fall down from an injury, like typically it's nothing really that you'd find concerning, but when you're like in your 40s, that might be something of concern. That might be something that makes you acknowledge your mortality. And so I found it, almost ironic that he falls down from something that basically makes him like acknowledge his mortality, and then that's the moment he meets Kilroy. So yeah, I found that really interesting.
Yeah,
And
one of the themes is that, as people enter midlife, they enter their 40s or 50s, they start to begin to notice some of the effects of aging, that injuries um, uh, don't heal as quick, don't recover as quickly. You get to catch a cold or the flu, it takes a little bit longer to get better. They find that they're not quite moving as fast as they used to. People in their 40s or 50s for the first time begin to notice some of the tip of the tongue phenomenon where you can't get the words right there, but you can't get it to come out. Or they find that they misplace things, or they go to the mall and park their car, and then increasingly come out and can't remember where they parked their car, and begin to have this sort of uh-oh moment, is it starting kind of thing. And they become really quite fearful, terrified, really, of what may be awaiting, the fate that Kilroy is already experiencing. And this creates a distancing. So you want to stay as clear away from folks like that as possible because they're a painful reminder, there, but by the grace of God go I. And if I'm fortunate enough to live long enough, I'm going to get there eventually. So nobody really wants to recognize or acknowledge that. And that's one of the challenges this fellow is facing.
right, yeah. Yeah, that was honestly a fascinating part of the story. Yeah, so next I wanted to move on to Kilroy's three sons and your characterization of them. So Jack, Bert, and Ray. I mean, I know they're fairly minor characters, but we see that one of them is constantly nagging, one of them is, frankly over-involved in his father's affairs, and the other one brings in research papers with driving statistics to convince his father to stop driving. But we don't necessarily see a whole lot of empathy or understanding from these three characters, despite the fact that, they're his own sons. So I wanted to ask, how, if so, this may relate to, real life experiences of elderly adults that, maybe you've seen in the clinic, or something of that sort.
Yeah, each is an archetype designed really to reflect my own experience of the three most common ways family members cope with their older relatives, mostly parents who are dealing with children probably in their 40s, 50s, or 60s, dealing with a parent who's become an impaired driver and is dangerous and shouldn't be behind the wheel any longer, but won't give up the keys. And the three common reactions are um, uh, tremendous anxiety. Oh my God, Dad's going to kill somebody, and I've had family members come in and tell me they lay awake at night worrying about Dad getting killed or killing somebody else, and maybe running over a mother and a child in a stroller, that kind of thing. The kind of terrified of their parent showing up on the front page of the paper or in the evening news. The usual story, 100-year-old man runs over people on sidewalk kind of thing, and they lose sleep over it, and they're paralyzed with fear and aren't able to take effective action. You have the warriors and the naggers who just relentlessly after people. You have family members who are kind of severe and militaristic, as one of the sons in this story is, who take a tough love. They would describe it as a tough love approach, but it's really kind of punitive, angry, and harsh. They're angry at their older relative for making them uncomfortable, for not being reasonable. In fact, these people often will bring a relative in to see me, and what they're looking for is they want me to talk sense into their parent. I think if a doctor, person with an MD after his degree, trained geriatric psychiatrist can talk some sense into him. Some of them actually said that. Please just talk some sense into him. And it's a very unsympathetic, unempathetic attitude. They have no sense of what their relative is going through. They're all focused on their own feelings. And then you have the intellectualizer, the person who will go on the internet, read a bunch of books, learn, study, develop an understanding of screening tools and measures for impaired driving and cognitive impairment, who will know all the data on driving statistics, crash death rate statistics among older adults, and the like, and will intellectualize it and want it to be viewed from a medical assessment point of view, like going into the eye doctor and getting an eye exam. If you, it's easy for the ophthalmologist because there are state level standards about vision. If you can't pass the eye exam with glasses or whatever corrective lenses you need, you can't drive. It's cut and dried. It's very simple. And they want to approach it that way. So they often will come in looking for some kind of test to tell whether or not their older relative is still safe to drive. And if they flunk the test, that's it. It's over. Take the keys away. They feel justified. But in all three cases, there's no real sense of appreciation for the deep um, personal crisis, the emotional crisis that this represents for their relative, and no effort or thought about how to help their relative over this really difficult challenge of aging, to sort of get past it and move on, and not let it define this period of their lives as much as it is.
Right. Yeah. I mean, those are all super important questions. And I think you do address some of that in your blog post, which is convenient because that's, my next set of questions. So your blog post, Dad's Driving is Driving Me Crazy. Don't forget to check your blind spot. Tackles a topic that so many families struggle with, addressing unsafe driving in older loved ones. Could you share the central message of the post and why you felt it was important to write about?
Um, yeah, again, because it's a common public health problem. In my experience, uh, people are really struggling with it. It has a potential to blow up in families, and I've seen cases where um, conflict over whether a parent can still drive or not, and disputes over that lead to major fights. They actually create conflict in families. Uh, Everybody's at each other's throat. I've seen estrangements result from it. I've actually seen people alter their wills and cut children out of the will because they thought they were being inappropriately treated. Nobody, our approach in our culture is from a public safety and legal perspective, but there's really nothing that's out there about the emotional challenge this poses to older adults. And it's really actually quite significant. And there's lots of good data that older adults that stop driving suffer a higher rate of anxiety and depression and decline cognitively faster. That it may actually, losing the ability to drive may be a risk for more rapid, more accelerated decline with aging. So we don't really address that at a clinical level, at a personal level. And when I actually set out after my nonfiction book on depression came out. I thought the next book I would write would be on driving, and I started to write that book. And people would ask me, "What are you working on?" And I would tell them I'm working on a book on driving. And almost 100% of people would say, "Oh boy, I can't wait till that comes out. Boy, do I need that." Or I wish I had something like that when I was dealing with my dad or my mom and couldn't figure out how to take the keys away. People are worried that it will, you hear commonly, if I take dad's keys away, it'll kill him, it'll finish him, it'll be the end of him. Or if I take mom's keys away, she'll never talk to me again. You hear these kinds of concerns, and there's just nothing out there to help people know how to address these problems in a skillful, emotionally sound way um, that can bring them closer to their relative rather than creating an emotional wedge between them.
Yeah, so this actually flows perfectly into my next question. So talking to aging parents about giving up driving is a conversation filled with emotional and practical challenges, as you've mentioned. So from your experience, what strategies or advice would you offer to families navigating this delicate topic?
Um, First is, number one is uh, patience and listening. You need to listen and be empathetic. So you can get to the point of getting the keys if you go through an emotionally sensitive process, an emotionally supportive process, and a process that supports and recognizes the worth, self-worth, and dignity of the person who's struggling. Secondly, I think it's really critical to start with a comprehensive geriatric medical evaluation because one of the problems with old age in our healthcare system is that it's not really prepared to deal with many of these problems very well. Old age is itself a risk factor for getting inadequate healthcare. So few specialists in few primary care or specialist physicians or other healthcare providers in this country are trained in geriatrics. Those of us who are few and far between and sometimes hard to find or not available. So there's a tendency to assume, well, somebody's 90 years old, of course they shouldn't drive anymore. When some of the things that may be making them impaired behind the wheel can be not only diagnosed, but treated and fixed and remediated. So I've had many patients who at one point couldn't drive, but with proper treatment were once again able to function pretty well, including being able to drive and getting their driver's license back. So you can't assume every form of disability in old age is irreversible and just what happens to you in par for the course with aging. Um, some of it, in some cases, a good amount of it can be treated and corrected. So that would be the first thing, would be to start with a good comprehensive evaluation. And then the real gold standard for deciding that somebody can or can't drive is a behind the wheel driving assessment. So one of the big mistakes people make is the relative will be evaluated by a primary care doctor or a neurologist or even a specialist like me, and they'll do a simple test of memory and other intellectual abilities, a kind of 30-point mini mental state or what's called the Moak exam, commonly used these days in clinical practice. Um, and they'll quote unquote flunk that test by getting a score that puts them below the cutoff for what we think is consistent with a diagnosis of Alzheimer's disease or related disorder. And someone will conclude based on that you can't drive. And that's really not fair to the older driver because many people who will flunk those quote unquote flunk those tests will do better if you retest them at another day at another time, maybe after they've had a good night's sleep or later in the day or earlier in the day. But also these don't correlate really well with driving ability. So I've had lots of patients who even that I thought couldn't drive, but we send them in for a driving evaluation, and lo and behold, they passed it with flying colors. So the state police officer who sits behind the wheel and watches them do their behind the wheel road tests, possibly the most severe critic of driving ability you're going to find anywhere, assesses them as capable of driving. It's good enough for me, but what it tells me is my ability in my office to know who shouldn't drive, shouldn't drive isn't as good as I'd like it to be. So you have to be humble about all this and really be thoughtful.
Thank you. Yeah. So this advice that you just provided actually got me thinking, what would you say would have been the best approach in the case of Kilroy in your story in terms of, what his neighbors could have done for him, what his sons could have done? What would you say they should have done better?
They need to do what Kerry is probably going to do, which is provide a combination of direct support. Like at the end of the story, she's thinking about driving him to the supermarket once a week to help him shop for groceries. And what that does really is it gets him out from behind the wheel, which he can't really drive anyway at this point. But it does it in a way by being with him, by sharing the experience with him. The other thing is that she's going to listen to his story. She's going to be impressed by his life's accomplishments. She's going to help him feel that he's lived a really good life. And although he's been through some very, very hard and horrific things and some terrible losses, he's managed to weather those storms, come through them, and and do okay in many ways. And in that process, really, rather than cause him to feel enfeebled and inferior and to lose his sense of self, she's going to help him remember the man he has been all along and still is in many ways. And that support for his self-esteem really ultimately makes it possible for him to come around at some point and surrender the keys without too much of an objection.
Right.
It's the sort of direct, fearful or angry, confrontive approach that makes people that backs people into a corner, gets their backs up and makes them resistant, kind of makes them react angrily and in the opposite way you want, in a kind of a passive aggressive way that always backfires and leads to no good that you want to avoid.
Right. Yeah. So there's clearly a huge emotional component to this, and it's definitely not black and white. But I was wondering, with the advent of artificial intelligence and all of these new emerging technologies we have today, do you see a future in which, these decisions could or should be automated to at least to a certain level? Or do you think that's, too far in the future, and we may not have that capability just yet?
No, and I actually don't think that at all. And there are a number of centers around the country looking at that are focusing on technology and aging, ways that technology and advanced technology can compensate for many of the challenges of aging. One of them being in more autonomously functioning automobiles. The challenge is whether or not if the car is driving itself, that improves, it solves part of the problem. It keeps the older adult mobile in many parts of our country. If you live in a city, you can take public transportation, assuming you're physically and mentally robust enough to manage that. But if you live in most of this country, a lot of it rural, and where I live, it's mountainous and very rarefied. If you can't drive, you're basically marooned at home.
Right.
So, a self-driving car to some extent solves that problem. And the technology hopefully will get us there fairly soon. And many older adults, I think, will adapt to that and really love it and use it effectively. For others, though, it doesn't solve the problem of loss of capability and prowess. So um, if the car is doing it for you, it means that you're not doing it for yourself anymore. And we're dealing with a generation. I mean, the divide now between digital natives and non-natives is becoming more and more stark. But people that are currently older certainly are not digital natives. I mean, these are people that grew up when you still have to crank the windows down manually in your car. Um, Nothing was automated or digitized. And I make that point in the story that one of the things about the Mercury Monterey Breezeway is it had electronic windows. You push the button and the windows go up and down.
Right.
Um, and that was a big innovation in the day. Now there's no car anywhere in the world made without that. But I'm old enough to remember when you had to crank the windows down manually. And so people that are in their 70s, 80s, and 90s now may not want all this technology doing these things for them, and they resent it as
Right.
an encroachment.
It's interesting. Yeah. So next I kind of wanted to discuss I think we've been talking about these issues in a very America-centric context. And I was curious about how these issues like translate to like other societies, other countries around the world that maybe aren't as car dependent and maybe more reliant on public transportation. So do you see the loss of driving as in elderly patients as primarily an American issue tied to our car-centric culture, or do you think it reflects a more universal challenge related to aging and
Only partially. Partially, it's interesting. I mean, as an American who grew up when the Detroit muscle cars were still the thing. I mean, I just wanted to have a supercharged car when I was a teenager. Um, you write what you know, so I know this culture very intimately, I think, but in doing the research, one of the things I discovered is that and I was surprised by this, but that. even in what we at one point referred to as third world countries, um, the aging of the population is becoming a bigger and bigger public health problem. And um, and driving has become a huge problem, and impaired older driving in almost every Western developed country is now a big issue. But even in places like India, Egypt, I'm trying to think, there are a few other countries that stand out that I'll remember in a minute, but you'd be surprised how many places, China, for example, this is becoming an increasing problem. So I think that it's become global. The whole world is dealing with the aging of the worldwide population. It's going to become a real challenge for planet Earth over the next 10 to 30 years that has to be addressed if bad things are not going to happen. And it's amazing how universal the automobile has become worldwide. I mean, think about it. I mean, everybody has a smartphone these days, and it's amazing how many people have automobiles and how many people have become very emotionally attached to their automobiles. There's something about it that really is compelling for most of us. Love affair with the car used to be a very American thing, but I actually think it's metastasized all over the world pretty well.
Yeah, yeah, for sure. So I guess switching gears now, for our listeners, I wanted to ask a couple of questions about yourself, and your professional experiences. So your dual expertise as a psychiatrist and an author is such an impactful combination. So in your work, do you see writing as a way to process and communicate the complexities of aging and mental health in ways that clinical work alone might not necessarily allow?
Clinical work is great. It's very rewarding, but it it provides benefit to one person and their family at a time. And that's great. It's extremely rewarding to do that. Very gratifying when people get better, when you see they come out of a crisis, especially when for me, I feel like I had an impact on that. I helped them overcome that. Maybe I help them take a better direction at a crossroads in their lives where things could have really gone bad. And I've had many family members, children in particular, send me really quite moving, endearing notes and say, thank you for everything you did for mom. You really saved her life. I mean, just to hear a psychiatrist talk about being told you saved somebody's life is pretty nice. But you gave her back to usually it's after they've died, and you get a note letting you know that they died, and they think enough a few years later to write and say, you gave her back to us for a good 5 years. The last 5 years of her life were really great, and we thank you for that. But it's one patient, one family at a time. Um, I think that I spent most of my career writing papers for academic medical journals based on research or other things that I was involved with in different university settings. And other people read that and are impacted by it, but it's a small audience really. It doesn't reach out to the public. And so I kind of decided that fiction would be a much more compelling tool that might reach more people in a ways that they would identify with and be moved by, and maybe even attitudes and beliefs and knowledge about aging could be changed that way as well.
Yeah, so this flows perfectly into my next question, which I think you've already answered partially. But fiction has a powerful ability to humanize social issues and spark conversations that might otherwise be difficult. And as you've mentioned, so how do you see storytelling playing a role in challenging ageism and shifting societal perceptions of aging at the macro level?
So obviously people need to read it to be impacted by it. But storytelling is the way. I mean, our brains are evolved over the years to tell stories and be affected by stories. That's what makes storytelling so effective, whether it's in the written form, in movies, and the like. We all respond. And if you look at, for example, even people don't pass legislation based on data. They pass legislation based on witness accounts of compelling stories that are moving and really make a case. I think that I have at this point 6 or 7 short stories in various stages of development, and I'm working on a novel. And each of these works tells various stories of older adults struggling with various different challenges of aging or mental health problems that often strike them for the first time in old age, catching them by surprise after they've lived the vast majority of their lives and enjoyed really, really good mental health. They've had the rug pulled out from under them in old age by an age-related, generally a medical or neurological problem that causes mental health or psychiatric complications, makes life really more miserable than it needs to be, threatens the quality of life in a way that no other healthcare problems do in old age. And so the characters that I write about are based on my own experience with real people I've treated over the years and their families, but they're designed to be recognizable, characters that readers will immediately recognize, identify with, begin to empathize with and feel for. And they illustrate whether it's coming from the first person point of view or a third person point of view, the perspective of these characters and what it's like for them dealing with what they're dealing with in old age, including the ageist bias of the culture they find themselves in.
Right. Yeah, yeah, that's definitely super important to talk about. I guess, bringing this conversation kind of to the broader discussion of aging, mental health, and independence. So your work highlights the mental health challenges of that older adults face, such as depression, anxiety, and the psychological toll of losing independence. So what do you see as the most significant challenges, whether through clinical work or research, and how can we as a society, through everyday actions, address them?
So um, the challenges are enormous, whether it's depression, anxiety, substance abuse problems that come to the fore for the first time in old age, complications of problems like Alzheimer's disease or related disorders, dementia, Parkinson's disease, and things of that sort. Or even PTSD for that matter. And Colonel Kilroy, my character in the story, actually has delayed onset PTSD. So he's because of his what's going on in his brain, he's having PTSD symptoms from his war experience that he never had when he was younger. Never had any difficulty related to that. They didn't even call it PTSD in those days, but um, these become huge problems for war veterans, other trauma survivors who manage to weather it and get through, and now in old age for the first time are developing out of the what appear to be out of the blue symptoms of PTSD. That's an aside. I would say that the number one challenge and the number one need is for people, older adults themselves, their families, their various medical healthcare providers, and all other older senior care workers who work with them is to recognize these problems are not inevitable parts of aging. It's just not what happens to you automatically when you get old. Getting old, being depressed, becoming quote unquote senile, it's just not par for the course. It's not normal any more than diabetes or high blood pressure or arthritis or anything else is a normal part of aging. They're problems that become more common with aging, but they can be diagnosed and treated often quite successfully. So we need to not sell older adults short, and they need to learn not to sell themselves short. They need to seek out and get effective, compassionate, knowledgeable medical care and make sure that everything that can be done is being done. You can't fix all problems of old age, but it's a tragedy when someone uh, declines faster than they need be, dies sooner than they need be, or winds up in a nursing home avoidably for a problem that could have been treated and when all these poor outcomes could have been prevented or put off 5 or 10 years. That's a tragedy.
Definitely. Yeah, thank you for that. So, in addition to your contributions to our journal, with the story about Kilroy, you've also written a book, a nonfiction book titled Beat Depression to Stay Healthier and Live Longer. So, what inspired you to write this book, and how does it complement your work in geriatric psychiatry?
So it's a great segue from what we were just talking about. So, depression is maybe the most common mental health problem affecting older adults. And the majority of older adults who are depressed don't ever get any treatment for it. And those who do get any treatment at all, the treatment they usually get is woefully inadequate and doesn't make them a bit better, which is a shame because we know that the vast majority of older adults with serious clinical depression respond just about as well as younger people do, and most of them, the vast majority of them will get better with concerted treatment. But nobody knows this. People themselves don't know it. I can't tell you how many patients I've seen over the years, and we try to explain, you've got a clinical depression, and they say, "Really? I just thought that's part of the deal with aging. That's not normal." And trying to help people understand this is a medical problem that's treatable. It's a brain disease, and trying to convince their families as well that it's just not who mom has become at this point, and there's nothing we can do about it. And even their doctors and nurses and other healthcare providers they work with to understand these are problems that need to be addressed. So I wrote this book focusing on helping people understand what depression is, that it's a medical illness due to changes in the physiology of the brain that become more common in old age because of age-related changes in the brain, but it's not an inevitable part of aging. But to make it more compelling, I basically made the case that in addition to really wrecking mental well-being and destroying quality of life in old age, depression is a risk factor for all kinds of bad health outcomes. We know that depression increases your chance of dying of heart disease. It doubles or quadruples your risk of dying for heart disease. It doubles your chance of having a stroke. It increases your risk of developing cancer, diabetes, or if you have diabetes, it makes it harder to control. It's associated with chronic pain. If you have chronic pain, it makes the chronic pain harder to control. It's associated with a worsening course of chronic kidney disease, and people who are depressed wind up on dialysis much earlier than people who are not depressed, uh, keeping the same level of kidney disease constant. It makes chronic lung disease worse. So if you ever known anybody with breathing problems who struggle with that, it's a miserable feeling when you can't get enough air. And to think that there's a mental health condition that makes that worse that can be treated and goes untreated is just horrible to think about. But the list goes on and on and on. People who are depressed are more likely to fall and fracture their hip. They're more likely to wind up in a nursing home. They're more likely, it doubles your chance of getting Alzheimer's disease or Parkinson's disease. And it doubles or triples your chance of dying over the next 5 years compared to other older adults with similar health who are not depressed. So I thought this story is pretty compelling. I figured, okay, you don't want to have treatment for depression, but if I tell you that your depression is going to double your chance of getting Alzheimer's disease and you don't want Alzheimer's disease, does that make you a little bit more interested in having treatment? And the answer is surprisingly yes. So I wrote the book with that message in mind. And each chapter has a clinical vignette, a case history that readers can identify with. And the case histories are based on my own experience, but they're snippets I cobbled together from case histories of my own patients, obviously fictionalized to protect the confidentiality of any individual patients. But what I discovered in the process is that writing a nonfiction book felt pretty tedious, except for the fictionalized personal accounts, the parts that involve writing, making up stories that were compelling and interesting and engaging, maybe with a little bit of humor sprinkled in there, was a lot of fun. I was having a good time doing that. So, and as I said earlier, when I set out to write my next nonfiction book on driving, it just felt like, why am I doing this? I'm going to give up this idea. I'm going to start to write fiction instead.
Yeah, I mean, thank you for all the work you do in bringing these issues to light. I mean, this was also very fascinating to hear about. So I mean, you've accomplished so much in both the clinical and the literary fields already. Are there any new projects or areas of focus that you're currently working on or excited about? I know you touched upon this a little earlier, a couple of fictional short stories. But yeah, I'd like to hear more about that.
Yeah, so I have a bunch of short stories. I have a short story about two older sisters who come together in their their family home, but neither one of them has lived in a long time. Their mother is now in rehab, and she's going to an assisted living facility. She's got dementia and has fallen and broken her hip and can't live alone anymore, and is going to assisted living. And they get together to try to identify some pieces of furniture and personal mementos and other things to make it more home-like, to move into her apartment in the facility. Families go through this all the time. It's a very common experience. Try to figure out what of mom or dad's things can we bring with him or her, so it'll be familiar and make him or her feel more at home. And the experience of being there and going through this triggers a whole lot of long dormant, unresolved sibling conflicts. And people who have read the story so far resonate with this because aging of a parent stirs up some long dormant family dysfunction that's been swept under the rug through most of adulthood. And it sort of comes roaring back out in ways that are often not so pretty. So I have a story that deals with that. I have a story about an older woman with depression who is struggling with the stigma of having a psychiatric problem. And she finds herself in the waiting room of a geriatric psychiatrist where she doesn't want to be. And she's confronted by another patient there, an older woman with dementia who freaks out as this goes, really just freaks out and becomes wildly agitated and is screaming hysterically. And in seeing the geriatric psychiatrist work with this patient, she has a transformation and becomes more open to the idea that maybe this fellow can be of help to her too. I've got a story about a man who seeks the help of a medium to conduct a seance to put him in touch with the spirit of his father in a way that it involves family conflict in which the challenge what he really wants to do is contest a will, which is a problem that comes up often in my practice, is that people come in and they have one agenda or another, but what's lurking underneath is they're eager to contest a will that they're not happy about. I've got a story about an older woman living alone with failing memory who hallucinates music played by a swing era small ensemble band in her attic. She hears musicians playing music in her attic, the stuff that she and her husband danced to when they were young and first got married. And the backstory is that the symptoms really represent a psychological manifestation of her unresolved conflicts over this marriage, which was started out with so much promise and wound up for so many reasons. Actually, one of them having to do with the Korean War as well, by coincidence, not turning out so good. So it really is a story reflecting the aftermath of having very mixed regrets and ambivalence about one's life and the life one's lived. And then I'm working on a novel. The novel is a framed narrative that tells the story. It tells the story of one day in the practice of a geriatric psychiatrist that allows readers to kind of pull the curtain back and see what goes on in a current medical practice, particularly to see how modern psychiatry is practiced and to see what geriatric psychiatrists do. Throughout the day, each chapter would meet a different patient, and it gives the reader a chance to read an interesting, engaging, again, fictional story about an older adult struggling with one mental health problem or another that I think many readers will recognize as familiar and be able to identify with, and helps them understand the way the way modern medicine, informed by cutting edge brain science, now understands these problems in a way that's different than the current lay understanding of psychiatry and mental health, and begins to provide some a kind of education about mental health and aging, psychiatry, and the brain and how we think about it. And then nested in there is a mystery character who shows up under strange and mysterious circumstances, in a way that's kind of threatening, but he's a genius who's kind of gone off the rails. And it provides an opportunity to explore themes that are interesting to me, which have to do with philosophy of mind and what current brain science tells us about how we think about those issues of the self and the mind. and it creates and there's suspense at the end, and somebody there's a gun and somebody's going to get shot. So it's kind of fun. It's fun and compelling to read and educational at the same time. I hope.
Yeah, I mean those works sound really exciting, and I would honestly love to read them when they come out for the public. So yeah, I mean that's awesome. Thanks for mentioning that. I mean, so today we've touched on so many important topics from your storytelling to the practical challenges of aging and mental health. It's been an incredibly enriching conversation. So thank you so much. Uh, Dr. Moak, before we wrap up, is there any final message or takeaway you'd like to leave with our listeners?
Once again, I can't, this point can't be stressed enough. If you're struggling with any type of mental health problem, or someone you know, a loved one, or someone you work with or care for, even if it's a neighbor, is struggling with a mental health problem as they've gotten older, particularly if it's a problem that's emerged for the first time in old age. Uh, don't assume it's just part of what's happening to them as they get older. They really need a good, thorough medical evaluation to see what might be causing it and what can be done to treat it, because more often than not, something can be done that's helpful.
Thank you again for joining us today and sharing your insights and stories. For those listening, you can find Dr. Gary Moak's work, including Mercury Descending and his blog post, on the Reapparition Journal website, reapparitionjournal.org. Stay tuned for our next episode and see you next time.